Greetings and welcome. I am Kathy Ann Reddick, president of the Thru Foundation, a nonprofit organization whose mission is to support and assist women who have been diagnosed with breast cancer and those that are in survivorship. It is my pleasure to work with Dr. Faye Stern, president and CEO of AdMeTech Foundation, and whose mission is to transform early detection and treatment of prostate cancer, especially among African American men and Latino men. So thank you all for joining us here today. We have a great group of speakers tonight, and we look forward to your questions and answers at the end of the program. So let's get started now with Senator Rush. Is the Senator on? Yes. He's the Senate Majority Whip here in Massachusetts, and he serves the communities of both Norfolk and Suffolk County. And on a personal note, it was great to see you, Senator Rush, on the Alpha Kappa Alpha breast cancer event recently. So thank you for your service to that event.
I think he needs a few more minutes.
Okay. Should we go with State Rep Jay Livingstone? So let me introduce State Representative Jay Livingstone of the 8th Suffolk District, which includes Cambridge. He is also the chair of the Joint Committee on Consumer Protection and Professional Licensure. Representative Livingstone, please, your comments.
Thank you. And thanks for holding this. Awareness of prostate cancer is key because so much is, it's such a common disease, and the more people are aware of it, the more screening. I was surprised to learn 1 in 8 men in the United States will be diagnosed with prostate cancer during their lifetime. It's the most common form of non-skin related cancer that people have. And it's one of those things that doesn't have early warning signs. And so being on top of it and getting screening is key. And with the pandemic, the last 18 months, people, for a variety of reasons, have been getting the what they perceive as non-essential medical treatment, and screening has definitely been impacted by that. Research tells us that there's also a great racial disparity, that Black men are 50 to 75% more likely to develop prostate cancer during their lifetime and are twice as likely to die from prostate cancer, which makes it even more crucial for African American men to get screened for this. And again, during the pandemic, much like the general population, African American men have gotten screened at a much lower rate than previously. And this is crucial because screening is going to save lives. If caught early, nearly 90% of prostate cancer is treatable. And people need to get screened really starting at about age 45, all African American men, and then other men with some sort of history of prostate in their family. And these issues have come to the state. There is, in the legislature, especially in the last year, much greater attention put on racial disparities. And in this particular case, it resulted in the 2020 budget, $1 million earmarked specifically for prostate screening awareness, specifically targeted at African American men and those of Hispanic or Latino heritage. AdMeTech was a great beneficiary of those because they're doing a great job. So including putting on programs like this to bring more attention to this issue. And it often flies on the radar, but it can be very deadly. But with screening caught early, it will make all the difference. And so I appreciate being asked to participate in this. But more importantly, I appreciate the attention that's being brought to this issue. So hopefully more people get screening. So thank you.
Thank you, Representative. We appreciate your comments. Reverend Brown, would you please give your comments?
Good evening. It's good to be with you. Some of you I met last year, and it's just good to be with you once more, especially in this difficult time. Again, my name is Reverend Brenda Brown. I am the senior pastor at the Massachusetts Avenue Baptist Church, which is one of the historical Baptist churches in Cambridge. And over at my church, I do run a food pantry and a soup kitchen. Our soup kitchen is ran twice a week. And in doing that, I have had, we've had screenings at our churches, we've had conversations, and so on and so forth. Within this last 18 months, due to the pandemic, I have not been able to have the hands-on, which I call my people. Mm-hmm. In order to see my people, we are still feeding, but we are feeding just on Monday. And our feeding look as, though we have to go into Central Square and deliver also in Mass and Cass, which is over there by the Boston Medical Center. And I'm making my duty at least once a month. My staff is minimum, but I'm making my duty to go into Central Square to see my people. And within the last couple of weeks, being at the church and in the good weather, I do open the doors on Monday. And there's a lot of unrest, easiness on some of my men that will stop by to see me. As a matter of fact, we having this meeting tonight. Within the last 2 or 3 months, 3 of my men has been diagnosed with prostate cancer. And it's very difficult to said to me they're being treated at the Cambridge City Hospital, and not having that hands-on like we used to or accustomed to in the soup kitchen, it leaves me at an awe on to how you're doing and how things are going. I was talking to one of my colleagues who's over there in Harvard Square that said to me, some of your guys are over here in Harvard Square, and I plan on going out there on next week to see what is going on. But it is a very hard, between prostate cancer and COVID vaccine, being in the church community, I'm seeing a lot of resistance on both. And I don't know how, in this arena, how we could touch it. And it's been very, very concerning to me. As I said, if we meet in house, I'm able, because I've got hands-on contact, go here, go there, and follow through. But with the COVID, it seems as though it's on the bottom end of the burner. So I am perplexed, and I'm looking to you guys on how I could be of more assistance in this area. Thank you.
Thank you. Thank you. So I'm going to go to our next speaker, Mr. Tony Clark from My Brother's Keeper, MBK in Cambridge. And one thing I'd like to make note of is that Tony and his organization actually held several vaccination sites in Cambridge, which went successfully, extremely successful. So Tony?
Yeah, well, thank you. Thank you for the invitation. And I was telling my wife earlier, every time I get involved with Kathy, I get in trouble. I start doing other things. So, I'm relatively new to this space. However, it's critically important as a man in my 40s now to be interested in this space. So much so, as I was, I guess, light preparing for this conversation, I was calling a couple of my friends who are in the medical field, and this essentially was like, what should I be thinking about? And a couple of things that they spoke to was continue to do the work that you guys started with your COVID vaccines around providing informational sessions, which Kathy has done so brilliantly here. In addition to that, I don't talk about this much, but I'm a graduate of Morehouse College. And so I called down to Morehouse School of Medicine and essentially was asking, what are some things that are going on there? And in typical fashion, kind of hanging out with Kathy, I decided to go down there on Monday. So actually on Monday, October 25th, I'll be in Atlanta for the day. And they're actually thinking about how do you map these kind of events out or informational sessions out for individuals in their 40s and their 50s. So I think in being part of this conversation, really a fly on the wall, but it's really intrigued me to kind of think about how we can do that work here in Cambridge and more so the region. I don't look at MBK Cambridge as a Cambridge specific organization, but more of a regional space because, as was mentioned with Kathy, when we provided when the Moderna vaccines were provided for the individuals, about 75% were from Cambridge, but 25% were from surrounding communities such as Medford and Somerville and pockets of Boston and even as far out as Randolph. And so I think it's critically important, and I don't say this because I think it's important, but the White House acknowledged our work, not because folks got shots in their arms, but because of the informational session prior. So I think this information here is so critical because it allows an individual to be curious. And I just say that I sit here as an individual looking to provide more informational sessions to folks like myself who have had kind of an aversion towards, being apart, going to the doctor, understanding what that means to me, right? And I think what happened was COVID happened, and it shifted the way in which I saw, my healthcare. I found myself at home a lot more. So, like a lot of folks, I got a Peloton, and I didn't want it to become a coat rack. Started running. Prior to this, I ran 2 marathons. I'm like, let me train for another one. It shocked me into a space. Yes, I ran 2 marathons, Kathy, in my lifetime, but it's kind of shocked me into kind of looking at things more pragmatically, but also looking at things from a communal standpoint. So, as I said earlier, I'm excited about going down to Atlanta for the day. And understanding what are some things that folks are doing, not just in Atlanta, but also spaces like Birmingham, Alabama, also Tuskegee, Alabama, which is a place I was told I need to look into as well, who are doing some work for folks who are in their early 50s, mid 40s, and they're looking at this more as a communal effort. And I would just lastly say that when you think about our region, despite the scarcity of Black and brown men in the Commonwealth, I do think it's an opportunity to galvanize for informational sessions unfortunately, because of the warts that COVID has provided us, with folks feeling as though they have been left out of the proverbial thoughts of this state. And I think this is an opportunity to kind of get folks back into a space, leveraging Zoom, but also going to parks and other mechanisms to engage. And I would lastly say it's exciting to be on here with clergy. I think that not only is this particular space around talking about prostate cancer a medical issue, but it's also a moral issue. And I think it's critically important myself and others understand this moment and re-engage the church as well. So I'll put a pin in it, and I just want to thank you for this opportunity. And I will bring back that information that I'll get on Monday. I'm excited about learning more and understanding a little bit more. Thank you.
Thank you, Tony, and look forward to hearing back your comments when you get back. Thank you so much. Next person I'm going to introduce, because it looks like Senator Rush is still on his call, is going to be Harold Cox. Harold is the Associate Dean for Public Health Practice and Associate Professor of Community Health Sciences at BU School of Public Health. So Harold, hello and welcome again.
Tony, I completely understand what you said about talking to Kathy. Anytime I get a telephone call, I know I'm in trouble, or I know that something's up. So I just get ready. I put my hand on my wallet first off to just make certain that it's still there. So I completely understand and just know that once you're in her Rolodex, you will always be there. So you're there. I want to talk a little bit about my experience with prostate cancer. It's so important to have a forum like this and the ones that we've had in the last couple of years, because it's important for us to hear about the science and hear about the medical activities, but it's also important for us to hear from people who have actually experienced prostate cancer as well. So I want to tell my story twice. The easy story is a number of years ago, about 10 years ago, I got diagnosed with prostate cancer, and we made a decision that I would have surgery. I had surgery and then dealt with some of the things that happen after surgery. That's the easy story. Now let me go back and fill in a little bit. Initially, I've been someone who regularly went to my doctor and would get the various exams that I needed to get. And on one occasion, I went to see the doctor, and the doctor, of course, gave me the dreaded digital rectal exam. Okay, it's known as the finger exam. Nobody likes to talk about it, but it is an important thing to do. The doctor gave me that exam, also gave me the PSA, and I'm going to let Dr. Carter talk about the PSA. But that's essentially the blood test. And they determined that there were my levels were not in normal ranges, and the doctor wanted me to go and see a urologist. I went to see the urologist. The urologist did a prostate biopsy and said, not anything really going on that we need to do anything right now. Went back another year. We did the same thing, had the various exams. I went to see the urologist as a follow-up, and he said, nothing's going on that we need to do anything about. A third year, I went back. The doctor did the digital rectal exam, did the PSA, this blood exam, this blood test. And then I went to the urologist, and this time the urologist said, you have something going on, and we need to deal with it. And then he asked me, so what do you want to do about it? Now, I got to tell you how complicated it is, first, to hear that there's something that's going on with my body, and then to have the doctor say, what do you want to do about it? So as he explained to me, it was a process that I needed to be engaged in. But what that meant was that I needed to go to several other specialists who were then going to tell me what they did, and then we would come back and we would have conversations. So I went to several specialists who actually then did their various examinations, told me about the radiological treatments that I could have, or maybe the surgery that I could have, or even trying to do nothing for a while. The doctor still is saying to me, what is it that you want to do? The good news is that between my internist and my urologist, I had wonderful counsel about the things that were available to me and the things that I needed to do. From all of the information that we shared together, we decided that surgery was my best option. And that meant that they were going to remove the prostate from my body. So I had to learn then, so what does that actually mean? What is going to actually happen? What does it mean when you lose your prostate? I had a wonderful urologist who was able to answer all of my questions, or as many questions as I had. And one of the things that he told me was that I needed to make certain that I was prepared for after the surgery, because after the surgery, there were going to be two things that were going to happen. One was that I was going to be incontinent, which meant that I was not going to have control over being able to urinate or being able to pee, and that I was also going to experience erectile dysfunction. The doctor told me that what I needed to do was to go and get diapers, because after dealing with the incontinence, I would have these accidents, and I needed to make certain that I was protecting myself. I didn't want anybody to know that I was going to be wearing male diapers. I didn't want anybody to know that. And I was convinced that if I went to my neighborhood CVS, that everybody that I knew was going to be there watching me get these diapers. So I decided that what I needed to do was to drive to Springfield, which is actually 90 miles from where I live. I drove to Springfield to get diapers. And when I got there, I went to the baby diaper section. Well, that's not where they are. I went to look for them, and I couldn't find them. And there was this woman who I found, the clerk, and I asked her, and she started looking around, and then she screamed out to her friend and said, "Where are the diapers?" Well, she kind of called me out. And I realized that nobody really cared that I was going to be wearing diapers. It really wasn't that important. And I drove all the way back to Boston, which is a long ways, with my purchase of my diapers. But I was laughing at myself and thinking, that was not something that I needed to be afraid of at all. I had the surgery, and as expected, the doctor told me that I would experience erectile dysfunction. I did. it's very complicated to actually deal with that. And so how do you manage that? And that was one of the things that I needed to learn how to manage and how to deal with. I think the thing that I have learned from this experience are several things. One, it's important for me to continue to get my medical exams. So I go annually and I see my doctor. Number two, it's important for me to talk to my doctor. I must tell you that there were things that I was embarrassed to talk to the doctor about. But in the reality, it was the most important thing that I could have actually done, to ask questions. Even though it was embarrassing to ask the questions, it was important for me to ask them. Number three, it's important for me to talk to my friends. So, Tony, I'm so very glad that you and Dr. Brown, Reverend Brown, are talking about doing activities in your community with your church and with the local community to talk to people about this. And it's true to not only, as you suggest, Tony, to talk to young men who are in their 40s and 50s, but also to talk to people who are in their 60s and their 70s, because we experience it at all levels as well. So it's important to talk. And perhaps the most important thing that I've learned is it's all right to be scared. Because I was definitely scared. I was scared of the unknown. I was scared of not knowing what to do. I was scared of, was I about to die? I was scared of everything. So it's all right to be scared. It's not all right not to do anything. You don't have that right. You don't have the right to just decide, I'm not going to do anything. People get afraid of going to see the doctor. I want to encourage you to do that. I want to encourage you to do the exams that the doctor suggests that you do. You will be all right. Kathy, I'm so glad that you do this presentation. And I offer my services to both Reverend Brown and to Tony as you think about how you want to reach out to various populations of people to talk about this very important topic.
Harold, thank you. I'm so proud of my team. And I'm glad to make these connections with Tony and Reverend Brown and Harold. I think it's going to be phenomenal. I do want to take a minute just to say a couple of things. Senator Rush has joined us, but I do want to keep with the momentum. So we're going to have Dr. Carter come on, and then Senator Rush, and then Katie Goldrick, if that's okay with everyone, time-wise. Okay, great. And I do want to say one quick thing. So my reason for being involved with this is, obviously I'm a breast cancer survivor, 10 years out. My dad was a prostate cancer survivor. He survived 30 years after his diagnosis. He also had the surgery. And when I met with Faye is when I found out that there's a familial tie between breast and prostate cancers. I had no idea. And I had gene testing. So there are many other genes out there that need to be tested. So I was really encouraged to work with AdMeTech and get the word out within my community. And I'm so proud of those of my friends who have come on board. And Dr. Carter, we're so grateful to have you with us today. So I'm going to say a little bit about you as I introduce you. So Dr. James Carter currently serves as a primary care physician at the Beth Israel Deaconess Medical Center. He is a graduate of the Howard University and George Washington Universities, followed by medical school, Georgetown University. He also received his master's degree from Harvard School of Public Health. Dr. Carter has held a number of clinical and administrative positions, including medical directorships of several local and national healthcare organizations. Dr. Carter receives wide recognition and multiple awards. We are so pleased to have you with us tonight, Dr. Carter. Thank you for joining us.
Thank you, Kathy, for inviting me. And I've been looking forward to this since I got the invitation. So thank you very much. It's great to see people that I know, like Harold Cox and others. And I think that Harold's experience is not an atypical one, and the way he presented it, and the anxiety about the diagnosis, and coming back and forth to the doctor, and not quite knowing what's going on. I've sort of been in the prostate cancer space now for about almost 30 years with screening and education. I joined a group called the Mass Prostate Cancer Coalition way back about 25 years ago, when they had these annual prostate cancer symposiums. and we've had now 24, I think, and I've done every one except for one. And I tell the story about the first one I did. I got asked by somebody at Dana if I wanted to talk about prostate cancer in African Americans at the symposium, and that was symposium number 2 about 25 years ago. And I said, sure, I'll do that. So I'm thinking that it's going to be a small workshop with 10 people, and I'd go in and talk about prostate cancer. So I walk into this room, and there's got to be 100 people in there, and there's a camera set up. And on the front row is Senator Bill Owens and Charlie Austin, all these survivors. And I did the program with a minister from one of the churches in Roxbury. And but it was sort of my first outing with the notion that you have to educate people to get screened. And that was the beginning of my starting to do work in education and screening. And I then took a job with Dana-Farber, a consultancy at Dana-Farber, which had the foresight to look back in 2004 and said that there are a lot of African Americans who are being diagnosed with prostate cancer late because they're not being educated and not being screened and not coming in. And let's go out and try to find these people and screen them and educate them. So for 10 years, me, along with the great educator Mark Kennedy, who's now with the Boston Public Health Commission, but Mark and I were a team going throughout the communities of Boston, and I actually and down to the Cape and to Rhode Island, educating and screening men of all types. But the program was directed to African Americans, trying to sort of decrease that disparity that the representative spoke about. We have about 1.8 times the rate of prostate cancer over white men, and we have about 2.5 times the mortality. The mortality piece we can try to explain away in a bit that men get diagnosed late and they come into this with more advanced disease and therefore end up with a lot higher mortality. The incidence piece is a little different because that goes back to issues of lifestyle and genetics and on and on and on, more complex issue. But we have to, in order to try to decrease that mortality associated with that increased incidence, we've got to be stronger on the education bit and stronger on the screening bit. Now, there's some pitfalls here. The pitfalls are these: that when we started doing this program, people were beating the drum about prostate cancer screening. It was a big deal. Everybody had to come and get their PSA blood test and get their digital rectal examination, or DRE we call them. And men don't come to the doctor just because of that exam. They don't want the examination, so they tend to steer clear of the doctor's office, thinking that we're going to do bad things to them. And the first thing they do, I mean, I'm a primary care doctor. Most cancer screening is done by primary care doctors. We do the screening, then we send them on to be treated and further evaluated. And they look in the room and they walk into the exam room and they look around for what might hurt them. They scan the room, trying to make sure there's nothing that's going to hurt them there. But we want to get these guys in. But so the PSA blood test started being used to screen for prostate cancer. It was not originally developed for that. It was originally developed to monitor men who had prostate cancer to see if they had recurrences. But very quickly, back at 25 or 30 years ago, it became part of the routine screening for prostate cancer. And in doing so, we ended up getting a lot of men with very benign disease, prostate cancer for sure, but prostate cancer that was not going to kill them, that they were going to die of a heart attack or stroke or some other cause 40 years later. And those men ended up getting operations. And with that were a lot of the complications associated with the surgery and all the incontinence that Harold talked about and all the other problems. And so there was a big pushback, and that pushback had an impact on African-American men. So the pushback was that doctors are diagnosing men with these cancers that don't need to be treated, so we should not screen. So people said, well, there's a prostate cancer treatment issue. No, there was an issue about the screening down the line that we had to make sure that we didn't miss anybody. So there was a pushback, and the U.S. Preventative Services Task Force, which regulates most of the primary care activities that we do and the screening that we do, said that screening for prostate cancer had a negative effect, that it gave it a D grade, that you shouldn't do it. There was not only was there no benefit, it was detrimental. And that was highly touted in the press, nationally and all over the place, that men should not be screened for prostate cancer. Now, That's all well and good if you're an average risk guy who's going to get very benign disease and live to be 99. But if you're an African American guy who's 45 or 50, who's got prostate cancer, but doesn't know it, and now feels that you don't have to be screening for it anymore, we're setting up a group that's going to be at risk. And I remember when the report came out, my wife called and said, you know, you don't have to worry about screening for prostate cancer anymore. And I said, where'd you get that? She said, I saw it on ABC News. Well, you know, a lot of people saw that, and it was tough to come back and try to get guys back in the doctor's office to be screened because they had heard that it doesn't do any good. But that didn't apply to them. Why? Because we got earlier disease and more advanced disease, and we got it 10 years before the white guys. And if we waited, we were going to be in a lot of trouble. And so we had a big pushback. There's a gentleman, Tom Farrington, who started a group called Prostate Health Education Network, or PHEN, P-H-E-N. And 17 years ago, we went to D.C., went to Capitol Hill, started having, you know, prostate cancer, African-American prostate cancer disparities summits. And we had, and they were on the Hill, sponsored by the Black Caucus, and allowed us to bring in the best speakers in the world to Washington to talk about prostate cancer, especially as it related to African American men who have these high mortality rates and these high incidence rates. And it allowed us to talk to all kinds of people. But one thing it allowed us to do, Harold, is that we were able to bring in the head of the task force as a speaker. And I moderated that session myself with somebody from 2 other cancer centers. And we talked about the issues with prostate cancer for African American men and how they were not being diagnosed in a timely fashion and how their mortality numbers were 2.5 times the white rate. I don't think she'd ever heard that before. And that session was done by 3 women physicians, researchers. I was just there as sort of the XY moderator. You know, I was just sitting there running the program. But they talked about this, and at that session, some decisions were made. And after a couple of years, the task force came back and started talking about now that it made sense to, in fact, screen men at higher than average risk. And who are those men? African-American men and white men, or any man who has a family history of prostate cancer. So those are not, you're not average risk if you're in that group, and therefore it makes sense to have a discussion about screening and using the PSA blood test. And so we're lucky that we're starting to now get more men to come back in and be screened and evaluated, especially African-American men because they're high risk. What I do personally with my patient population, and what Harold would have loved to have had a few years ago, is that when I see a patient whose numbers have bumped up, the PSA has gone up higher than normal, and I don't use the standards. I don't use 0 to 4 for African American men. If you get to 3, I want to see you more frequently because I want to know that number is not moving too fast. And I get those guys in, and when I evaluate them, and I say you need to go to your urologist, but here's what you need to say to the urologist. You tell them Carter said you need an MRI, okay? Because the MRI would allow you to pick up those cancers that got missed on the first couple of biopsies. Why? Because they couldn't see them. The biopsies are done typically with ultrasounds. The ultrasound will not find that cancer in there if it's small, even though they could be deadly. And you get the biopsy and the needle missed the tumor. And all of a sudden, you know, you have to go back 2 or 3 times. And finally you say, we found something. But if you're lucky and you get an MRI, you're lucky enough to pick that thing up the first time you put the needle in the spot, you make a diagnosis, you get your treatment. And maybe, you know, the treatment's a different kind of treatment. Maybe you don't have to have surgery. Maybe you can have a radiation treatment. Maybe you can have seed implants or other treatments that are sort of less, you know, extreme for patients and have less side effects. So I'm a big proponent of getting guys in and screening them. I'm a big proponent of education. I think education is the key. I think we need to start screening African-American men at 40. And I know that, Tony, you understand what I'm saying? That's a good time to get started because you want to know what you're at risk for. And that's a good time to get a baseline PSA blood test. We have a project going right now here at the Brigham and Dana and the BI, trying to find out what is the ideal time to do that PSA. Because there's some data to suggest that if we get a certain number on Tony at age 42, then maybe I don't have to screen him for another 3 years because I know that in this group, nothing's going to happen. But we don't have that information yet. Nobody has it. Why? Because it hasn't been done. And we want to be able to do that. And we're working on that right now. But there's a lot to be done in this field. But we have to keep the guys educated. We have to beat the drums that you have to be educated about prostate cancer and men's health issues. and get screened. Get your PSA blood test done. If you don't want the DRE, I tell my patients, you don't want the digital rectal examination, I'll take the PSA, because most of the cancers we pick up are picked up with the PSA. But there's some that are missed, and that's the reason for the need for the DRE. But I'll take the PSA in a minute if I'm going to get it. If I'm not going to get anything else, I'll take the PSA. And we, just to maybe take a break here, is to say that we, over the course of 10 years, screened and educated more than 5,000 men here in the Boston area with that Dana-Farber program. It's a wonderful program. We stopped that in 2014. Why? Because of the controversy about prostate cancer screening.
Dr. Carter, thank you so much. That was wonderful. I'm the program is going so absolutely well, and part of the reason why we wanted to pull everybody together too was to talk about prostate cancer awareness and prostate cancer in the time of COVID. And Katie Goldrick, who's the chair of the Holbrook Board of Health, we asked her to come on and talk about specifically COVID, the issues of COVID at this time during the pandemic with all cancers, because people are being pushed back, they're scared to go in. Senator Rush, if you have some time, would you mind coming in after? Thank you. I appreciate that. And then, of course, we will hear from the president of AdMeTech, Dr. Stern, who has a phenomenal presentation. So, Katie, if you wouldn't mind, thank you.
Certainly, thank you. Good evening, everyone. My name is Katie Goldrick. I'm the chairman of the Holbrook Board of Health, and I've been involved with AdMeTech for a couple years now, and really, as a small town on the South Shore, trying to educate the public. Really, when it comes to public health on a community level, we really focus on two things. We focus on the community level, like the boots on the ground. What can we do on to directly affect and impact our community, and its prevention? So whether that's COVID, whether that's educating about prostate cancer or breast health, breast cancer, it really is about prevention and education. So with regards to COVID and impacting a community, the same racial disparities that apply to prostate health also apply to COVID. We realize that when we want to connect to different ages and different parts of our town and different community network groups and community neighborhood groups, we really had to think hard how to get the information out there, how to get resources out there, and which resources those people may need. So what I wanted to do is talk very briefly about resources on a community level that if you are suffering during this COVID pandemic, that are available to us. And those would be things like, obviously, eviction help. I know that rent is a significant issue for people who are renting, especially if you're going through an illness, sickness of COVID. But there's also eviction guidance help and financial support for small landlords. Small landlords have been affected by this pretty badly as well. It's for the people who don't own large buildings, it's just one or two, or might be one additional home. It's impacted maybe your direct income. So there are state resources. There certainly is food help. Food pantries have really saved our community. We have seen a significant, I'm sure Reverend Brown has noticed a significant increase in the community that she serves. Our food pantries, if so with this small town, let's say we might see 20, 30 cars every couple of weeks. It can go up to 120, 200 cars. So food insecurity is a very real thing. Homebound vaccines, homebound care, homebound just effort. We had to recognize in our community who doesn't have resources at all, and how do we get those services to them? There is funeral assistance provided by the state for anyone who lost a loved one to COVID-19, and you know, when someone does pass away, and especially if it's unexpected, the financial burden is pretty extreme. The state has come up with a program to assist for anyone that was impacted in that way. There is free transportation to vaccine sites if you are a Mass Health covered member as well. So the state has done a pretty decent job with starting up those programs. And then on a community level, it was our responsibility to relay that information. And then, of course, when it comes to vaccinations, the hesitancy is very much still there. It is something that is new and potentially scary. And you know, there is a lot of poor information out there, and that did not help at all. And maybe a history of distrust of just general health to people of color in the past. That's some of the feedback we have gotten as well. So on my level, in a small community, we have been very fortunate. In fact, this past Saturday, we had a special town election. And we're really proud to say that for the first time in our 149-year history, we have elected a person of color to our select board. So we're very extremely happy with that. And I haven't told him yet, but I'm definitely going to bring him in as an advocate on this subject. And I, you know, maybe we could welcome him in the future for future talks we're looking forward to some really great impacts he can make, not only in our community, but on the outreach that we will need for certain, especially our surrounding towns as well. Our partners in Randolph, our partners in Brockton. So we're looking forward to that. So let's talk about a little bit about vaccines. I think originally I was scheduled to be like the last person to speak, but what I wanted to say with regards to vaccines is I think this is the way to get out of it. I think vaccine rollout will happen for the 5 to 11-year-olds. I believe the approval will probably come within the next couple of days from the CDC. I know the FDA has already kind of given it the go-ahead. So Massachusetts as a whole, we are already 79% of our residents have received at least one dose. We're almost 70% fully vaccinated. So we should be very proud of that. Those are really high numbers, especially compared to a lot of other states. We are doing well. And, you know, just like everything else with COVID, and it changes, while the COVID-19 vaccines continue to be remarkably effective in reducing severe disease, hospitalizations, and death, the CDC has said the protection provided by the vaccine would waver over time or wane, especially among the higher risk or those who are vaccinated in the early part of the vaccination rollout. So for that reason, a booster shot is needed to maximize the vaccine-induced protection and to prolong its durability. So the recommendation so far from the CDC is for Pfizer, and I would not be surprised if tomorrow Moderna and Johnson & Johnson joined that. So right now on a community level, what we're doing is focusing on the education on who is eligible for a booster. So that would be certain individuals who received, certain individuals who are 65 years of age and older, or if you're age 18 to 64 with underlying health conditions, or if you work, if your occupation or institutional setting puts you at a higher risk for COVID. So that's where really we're focusing right now. And we are reaching out to our church groups. We are reaching out to our Chamber of Commerce. Randolph, for example, has a Haitian Chamber of Commerce, also has a Randolph, Stoughton, like kind of conglomerate Chamber of Commerce. So we're really trying to almost the same pathways when I was trying to promote our prostate health care in Holbrook. I'm trying to use those same pathways for COVID-19 as well, because the outreach is really important. It's really the only way to get our vaccine percentage up and for us to get through this pandemic, and vaccines, I think, is the way to do it. Thank you.
Thank you, Katie. Thank you so much for that information. Senator Rush, thanks so much for hanging out with us.
Good evening. Thank you, Kathy. How you doing tonight? How's everyone doing? Great. It's great to be here with you this evening. And, it's so important because, as all of you know, if we don't continue to talk about important issues, maybe nobody's listening or paying attention. And that's why these forums are just critically important. I want to thank Representative Livingstone, who's a dear friend, and great to work with him on important issues at the State House. Great information and great stories shared here this evening. As you know, some of you know, some of you may not, I am an Iraq War veteran and have had the privilege of chairing the Veterans Affairs Committee for 4 terms at the State House. And I have joined you in the past, and I'm here again this year to talk just briefly about the importance of prostate cancer awareness and advocacy. And Harold told an incredible story earlier, and thank you for sharing that very personal story. But it's those personal stories that make the ultimate differences. So it was just great to be with you to hear that. As many of you know, some statistics in the last 10 years, out of 40,000 new cases of cancer among veterans, prostate cancer roughly would account for about 12,000 veterans per 40,000 cases, representing as large as a fraction of 30% of all cancer in veterans. And the highest percentage was much like national trends, statewide trends, to our African-American service members. And this just is unacceptable. And as some of you may or may not know, the VA healthcare system made it a priority and continues to make it a priority to get rid of this disparity. And they've done a pretty good job. They've done a very good job at it, actually. Cancer and prostate cancer in particularly, many of us know is service-related in many of our service members due to service members' exposure to herbicides in Iraq and Afghanistan, burn pits, our Vietnam veterans, Agent Orange. Consequently, veterans are considered high-risk individuals for getting and dying from prostate cancer. But the VA has done a very good job at stepping up. And I think they can be a model for the rest of the healthcare system to look at to try to eliminate these disparities. We heard great information, Dr. Carter, earlier. Some really good, powerful testimony here tonight in the direction we should be moving towards. And again, I'm grateful to be able to advocate for veterans, but to use the VA healthcare in best practices and look at those to expand statewide. I, as all of you, support statewide programs in prostate cancer research, education, and awareness. And again, I go back to my opening statements. Us being here tonight and us having these conversations and continued conversations, it can't be a one-time conversation. They need to continue, and they need to be heard over and over. And as all of us know here, particularly in Massachusetts, it's when the people speak that real change happens on Beacon Hill, and ultimately the end goal being a positive step forwards for the betterment and healthcare of our citizenry here in Massachusetts. So I am honored on behalf of the Massachusetts Senate to join you this evening, and thank you for all that each and every one of you do Thank you so much.
Thank you, Senator Rush. It's a privilege to see you. And as I said earlier, I don't know if you missed it, I recently saw you were at the Alpha Kappa Alpha breast cancer event. So thank you. Thank you.
I appreciate it, Kathy. Thank you so much.
You're welcome.
And I apologize for being late this evening. I was on another Zoom that ran a little long, honoring our Rosendale Community Health Center here in my district. So,
well, we can't be mad at you for doing the business of the people. Thank you so much.
Thank you, Kathy. Thank you.
Okay, next up is, I'm so pleased to introduce to you Dr. Faye Stern, who is the president and CEO of AdMeTech Foundation. She's also served multiple leadership positions at the National Institute of Health and U.S. Department of Health and Human Services, and at Beth Israel Deaconess Medical Center and Boston Children's Hospital. Harvard Medical School, she has a plethora of experience as a clinician. She has been leading groundbreaking state, national, and international programs in prostate cancer and breast cancer research. Education, awareness, and advocacy, creating a new standard of patient care and reducing health disparities. She is a recipient of multiple commendations and awards. She is an amazing woman who has made it her life to break down the barriers in communities to make sure that the healthcare gets out to everybody. And I'm so proud to introduce to you Dr. Faye Stern.
Thank you so much, Kathy. Really, I appreciate your organizing this event. I'm grateful to you for your partnership. In particular, I would like to thank Senator Rush and Representative Livingstone for their championship for many, many years of our program that makes events like we have today possible. I would like to start actually from a couple of points made by previous speakers. Dr. Rush just pointed out that VA and actually military system, a military health system, created this national standard. They were the first major health systems to eliminate health disparities in prostate cancer in terms of mortality. There was a large study from the system that came out in late January 2020 that demonstrated that with equal access, there were equal outcomes. And these results did not depend on the level of education or on the level of income. And we had similar results in the military system. There are clear differences in biology, in genetics, between Black and white men in prostate cancer. And yet access to care, as we learned from VA and military system, access particularly to high quality of care overrides any kind of biological differences between Black and white men. I actually prepared a more detailed presentation, and we pre-recorded it in order to avoid any possible internet instability and related problems. So Ali, if you can please help me go ahead with the video. I would like to start by expressing my gratitude to Kathy Reddick for the opportunity to address prostate cancer awareness in the times of COVID pandemic. This event is a part of the AdMeTech Foundation's ongoing program in prostate cancer awareness and education in Massachusetts, with primary focus on African American and Hispanic men. Our program was initiated since 2014 in partnership with multiple local community organizations and championed by Senator Mike Rush and Representative Jay Livingston, who are taking part in this event today. Both COVID-19 and prostate cancer have emerged as leading health disparities in Black and Hispanic communities. In April last year, early in the pandemic, we have recognized that the areas of prostate health disparities directly overlap with the pandemic hotspots. Since May 2020, we have expanded our program to include education about prostate cancer and COVID-19. Prevention and early detection are critical for saving lives and eliminating disparities in both prostate cancer and COVID. The future of this pandemic depends on us. What can we do to end this pandemic and protect our families and communities? We can drive down infections drastically by wearing masks, particularly indoors or in crowded outdoor settings, in combination with reducing social contacts. If we develop flu-like symptoms, we can ensure early testing and self-isolation and help public health experts to trace our contacts. We can end this pandemic by complying with vaccinations. Masks are the best tool we have for preventing spread of infection. On this slide, you can see predictions from the leading medical forecasting group at University of Washington as recent as October 15. If most of us use masks, our state is predicted to have less than 600 cases per day by January 1, including asymptomatic infections that may go undetected. In sharp contrast, if the current low compliance with masks continues, our state will have over 6,000 cases every day at the same time. Vaccines are the best tool we have for ending this pandemic. On September 13, CDC reported that in fully vaccinated people, infections were reduced 5 times, with hospitalizations and death reduced over 10 times. COVID vaccines have been proven safe and effective in millions of people aged 12 and older. We are much more likely to get into a car accident and sustain a serious injury than develop significant complications of COVID vaccines. Many experts pointed out that the vaccines could have prevented over 97% of hospitalizations and death we are seeing today. Vaccines are the best way to protect not only ourselves, but also our families and our communities. By accepting vaccinations, every individual help us get one step closer to ending this pandemic. Since early last year, more than 5 million children were diagnosed with COVID. In the first week of September only, new COVID cases in kids reached record levels, and the situation is expected to get worse. Our masks and our vaccinations protect our children. In mid-September, Boston Globe columnist Renee Graham wrote an opinion, "The unvaccinated and the orphans they leave behind." Citing scientific evidence, she pointed out that 120,000 kids lost their parents or caregivers to COVID in this country, with Black kids impacted disproportionately. She raised an important question. Can we allow our hesitancy and fear of the COVID vaccines define our kids' future? Several months ago, U.S. Surgeon General Dr. Vivek Murthy shared publicly that he lost 10 members of his family to COVID. He pointed out the masks help us reduce spread of infection, while vaccinations remain the bedrock of ending this pandemic. While we are dealing with the pandemic, prostate cancer cannot wait. And yet many men avoid visits to their doctors out of understandable fear of contracting the virus. Unfortunately, delays in care can cause reduced quality of life and even loss of life. It is important to point out that clinical facilities created a safe environment for patient care, including virtual visits and telehealth, ongoing in-person care such as physicians' visits and testing, medical procedures, biopsy, and treatment. Ongoing care is particularly important for Black, including Hispanic men, who are 2.5 times more likely to die compared to Caucasian men. However, early detection saves lives and eliminates health disparities. With early detection of prostate cancer, every man is alive in 5 years. In sharp contrast, with late diagnosis, when cancer is spread to other organs, only 28% of men remain alive at the same time. In prostate cancer, screening with blood test called PSA is the best tool we have for prevention and early detection, critical for saving lives and reducing health disparities. During pandemic, it is more important than ever to take charge of your prostate health. It is important to know your risk factors such as African ancestry, family history of prostate cancer, particularly brother or father, and increasing age, 50 years and older. You can ensure early detection. During annual visit, ask your doctor about PSA blood test and digital rectal exam. You need to talk to your doctor starting at the age of 40 if you have risk factors, or at the age of 45 if you do not have risk factors. Before screening, it is important to avoid exercise or sex, which may impact your testing results for 1 week. After screening, you need to ask your doctor if your test is normal or if you need referral to a prostate cancer expert. 2 weeks ago, AdMeTech Foundation held a virtual global summit on precision diagnosis and treatment of prostate cancer. Our goal is threefold: educating medical community and general public, reaching consensus on the best clinical practices and research priorities, and expediting transfer of the cutting-edge advances in diagnosis and treatment to patients. Screening of prostate cancer reduces death by more than 50% and has been more successful in that regard than many other established cancer screening programs. Our summit has brought together the key international experts representing every clinical expertise who highlighted the important advances in screening, diagnosis, and treatment. In men before diagnosis of prostate cancer, we have seen rapid advances in diagnostics, including rapid development of blood and urine tests for molecular markers and imaging tools such as MRI, which created a new standard of care. We have also seen that integration of molecular markers and imaging improves identification of men who are at higher clinical risk of life-threatening prostate cancer and need to undergo biopsies. Conversely, these accurate diagnostics also eliminated a large number of unnecessary biopsies. Our summit suggested that at this point, men who are referred for biopsy based on PSA screening alone should ask for additional testing to determine more accurately if biopsy is needed. I think it is fair to say that traditional biopsy, which is blind to prostate cancer and performed without accurate imaging such as MRI, is slowly but surely moving into the dustbin of history. In this slide, MRI guides biopsy needles to prostate lesions with great precision. Health disparities of our summit highlighted the importance of MRI in Black men who are likely to have lesions in the front part of the prostate that cannot be reached by physical exam or traditional blind biopsies. Our summit also highlighted the importance of assessing genetic predisposition to prostate cancer. Testing for genetic mutations is particularly relevant for men with family history of life-threatening prostate cancer and other malignancies, as well as for men with high-risk local, regional, or metastatic prostate cancer. Genetic counseling is preferred prior to testing for men with family history and after positive test for genetic mutations. In men with proven prostate cancer, there are two pillars of the current diagnostics, MRI and genetics. While MRI shows cancer location, genetic analysis reveals underlying cancer biology, indicating the likelihood of clinical progression. With this precision, we can now accurately determine if each individual has a harmless disease and needs only careful observation, or an aggressive prostate cancer requiring immediate treatment. Our summit's health disparities panel concluded that access to care is the key factor in eliminating health disparities. It is particularly relevant to our state with its universal access to care. We are here today because with appropriate patient education, combined with access to high quality care, we will be able to achieve prostate cancer equity in Massachusetts. To achieve this goal, we recently expanded our community education and public awareness to include a program for improving access of African American and Hispanic men to high quality clinical care. To achieve that, we have been working with leading state experts in prostate cancer care and research who have the most advanced diagnostic and therapeutic resources available today. In parallel, we are leveraging extensive partnerships AdMeTech has built with multiple community organizations to let everyone know about this opportunity. This organization include, but are not limited to, Kathy and Reddick's Live Through It Foundation, New England Area Conference of NAACP and its local branches, and Latino Health Insurance Program. This program is open to any individual who would like an expert consultation or receive a second expert opinion about every aspect of patient care. For example, men who would like to discuss questions if screening is right for them, or their screening results to consider if further non-invasive testing is needed prior to biopsy. Possibility of invasive biopsy and related choices. Family history of prostate cancer and possibility of genetic testing. Diagnosis of prostate cancer and related treatment options. Complications experienced after biopsy or treatment. Evaluation after treatment to ensure early detection of cancer return or progression. Summer Mills, a member of our staff, serves as a statewide clinical coordinator. If you have any questions, please contact Summer by phone 617-523-3535 or by email equityprojectcoordinator@admetechfoundation.org. In summary, prevention and early detection and related public awareness and education save lives and reduce health disparities in both COVID and prostate cancer. Masks and vaccination prevent COVID infections, hospitalizations, and death. Advances in screening and diagnosis created a precision, individualized approach to prostate cancer care. Thank you for your attention.
Thank you, Faye. That was an exceptional presentation. And the Equity Project is an exciting project coming forward. So Live Through It Foundation is very proud to be part of that. And, you know, I just, you know, it's continuing in, you know, when I think of it, I think of my father, you know, being 65 years old, having to have the prostate cancer surgery. And when he first was diagnosed, he thought, as they called it, he was from the South, the big C, that he was gone. He lived out 30 more years, very happily. So we have to get men earlier than 65 so that you don't have to always have to have the surgeries. But thank you so much for the work that you're doing. Are there any questions from the panelists?
So this is Harold. And I have both a comment for Jacques and a question for Tony. So, Jacques, I'm so very glad to hear about how you would deal with my case now. Obviously, 12 years ago, we were dealing with a different picture, dealing with a different understanding of the disease, dealing with a lot of different technology. So you know the experience that I have had of having 3 biopsies and et cetera. So I'm grateful to hear that there are new processes, and also grateful to hear about the technique that you would have of, so don't get a DRE, you know, stay away from it if that's a problem for people, and just encourage people to just get a needle stick and to take the blood test. So kudos to you for both the technology as well as the approaches that you are using in getting men in for service. And Tony, to you, I'm struck with and pleased with the comments that you've made about the importance of talking to men, especially younger men who are in their 40s and maybe even younger. And I'm wondering from your perspective, so what are young men thinking right now? I haven't been that age for a really long time, so it's kind of out of my bailiwick. But what is the sense of young men in going to a doctor and the kind of challenge that we have of getting young men to begin to think about their health?
It's a great question. I think that it's interesting. As we're going through this, I actually text Kathy, and when he mentioned the different options, the blood option, and I said I would like that. And so I do think that, like a lot of things, it's you're dealing with sometimes class demarcations, right? And so I remember I'm the Morehouse College class of 1998, so most of my peers, we've turned 45 this year. And I went online a couple of weeks ago, folks were like, I got screened, or I got my, it was really, they were excited about it, right? And I guess like a lot of folks, I was like, I'll hold off to my birthday. And my birthday was last week. So it's funny, we're here today. And when I heard about the blood option, I text Kathy immediately. And then what I also did was I text some of my colleagues at MBK. And I was like, you think we can get 20 brothers to do this? And they were like, yes. But I also want to caution on that those are individuals like who are probably on this call right now, right? So they're intrigued by this. So I think part of it is like how do we engage, places where it's high density, right? So our housing developments, communities where they're dealing with broadband issues, so they're not on this particular Zoom right now, right? There's a myriad of other things that I particularly think about, and with respect to engagement, and I can't, we're not a monolithic, but I would say from COVID, I think we've also missed an opportunity to educate about just the opportunity to get better, to get healthier. I think it's become this class piece where, well, if you don't get it, you're not smart, right? We also created some fear mongering. If you don't get the shot, you're not listening or you're not paying attention. But also, you have to think about there are communities that have felt as though they have overwhelmingly not have had access to adequate health care. And so now you're telling us in this pandemic, we're going to give you, access to healthcare or access to look at your health and be conscientious about it. And that's a pretty tough paradigm shift to make. So I do think that my cohort of folks are excited. So much so, like I said, they were posting online. I don't think I'm going to do that, but I'm not going to do that. But I will say that I do think there is an opportunity to get folks engaged. But I do think it starts with the education piece. And I think we missed an opportunity, in my opinion, with COVID in a lot of ways. And the opportunity is still here, unfortunately, to educate folks about that particular matter. But I think also this as well, how do you take this to the streets, if you may? So I do think there's an opportunity to create some spaces and work with, the policymakers on here, and but also corporations, and say, look, can we utilize that big field that you may have, or you may sponsor? Can we have a parking lot to kind of speak to folks? Can we have a cookout? Oh, maybe not cookout now, but can we provide, opportunities in that? And I think lastly, as we're talking here today, last Christmas, we gave about $20,000 of gift cards to families in need, for the holidays, specifically around food. We dealt with food cards. And we're going to do that again in November. But I do think it would be smarter because in Cambridge and other places around here, you have to have that 10 cents bag. I guess we have some policymakers here, so maybe I can, gripe about that with them on the call. Like, where's that 10 cents going? But our idea is to put together. We have bags being made with the food card, but it'd be great if we had some other things in those bags around prostate screenings and other things, because what we saw last year, and I'll put a pin in it, was that, we also did our own, we made some own, our own perceptions. We thought we're going to have overwhelmingly single caretakers that were going to be women. And it was about 45% were men who had sought out cards, right? Food cards. And so I think those are opportunities to put in some information around breast cancer and prostate cancer and And so, like I said, I'll circle back with Kathy about that. But I do think that's an opportunity. And lastly, with that, the age group that we were working with primarily ranged from 28 to about 43. So it wasn't, it's still in that kind of, that group of folks that kind of fit the demographic that they're speaking to, that I work with or have been around. So I think there's great opportunity. I do think, just to caution that, I think my friends don't have an aversion as much to going to the doctor, but I do have to keep in mind my cousins do. And I'm really here to kind of encourage my cousins to do it, because when the doctor had mentioned, I text Kathy, and then when you talked about working, helping us out, I'm like, how do I get in contact with him in the back of my mind? Because I do think there's a subgroup that does want to do this work, and we have a moment. We're in a moment right now. I think sometimes we're wasting it, because folks are engaged, a lot more engaged than they've ever been. But thank you for the question. Hopefully that was helpful, not too verbose.
I appreciate what you actually had to say, and I especially, I think we're always thinking, and I bet Jock, you can speak to this, of always thinking about how do you get men, especially black men, period, but especially black men, to begin to think about their health. And certainly the group of men that you're talking about, age 28 up to the early 40s, it's important for them to get exposed to the idea of going to a doctor. They may be at a place in their lives where they are experiencing less health issues and probably no health issues at all. But it's important to be able to get that mindset of, it's all right to go to the doctor. So that when you get to be 45, and congratulations to you.
Thank you.
It's important then to know that, so now's the place where I need to start stepping it up. But Jock, I bet you deal with this all the time.
All the time. And the truth is that when you feel good, you don't want to go to the doctor. So you see the average guy who's 40 years old, you ask him, when did he last go to the doctor? When he fell and hurt his knee. Went to the emergency room, no follow-up. Why? Because you feel great. You get an ache or pain, and you say, I'm not going to go because it's going to get better. And sure enough, 99% of the time, a week later, it's gone. So it sort of reinforces the fact that you don't need to go to the doctor. And you finally drag some of these guys in at 45 or 50, now they got a problem. They got cardiac issues, they got diabetes they didn't know they had, they got hypertension that hadn't been checked in 15 years, that sometimes had the impact on their heart and their kidneys, on and on and on. So we got to find a way to sort of beat the drum to get some of these younger guys out in their 30s to start getting routine health care. I've done some programs on that, just trying to get them out. And another way to go is to try to get the ladies involved in these cases. You do that, you get the girlfriends involved and the wives and significant others. Sometimes that'll bring these guys in. When we had the program, the prostate van for Dana, we'd wait and we'd park, and the women would bring the guys in. They'd be walking down the street and they see the van and they say, hey, you got to go on. They would resist, but they came on. And that's what we have to do. We have to find programs like Tony's talking about to get some of the younger guys in. We can do that. And there are a lot of organizations around who would love to be involved in that. UMass Boston, other places would love to get involved in some kind of programs to get younger men involved in health.
Yeah, let me just mention that, this idea of making certain, sometimes the reason that men go in for care is because their significant others, their wives, girlfriends, others, actually say, you're going. So it is important that these messages are actually being heard by not only men, but by women, because they are the ones who will actually say, you are going. Senator and representatives who are still here, I'm so grateful that you actually continue to push money out into the Department of Public Health, because it's there that programs like prostate education and breast cancer awareness and all those other programs continue to be funded, not only at the state level, but across the whole Commonwealth. So I congratulate you for continuing to be here and to champion this and call to your attention the need for dollars that will actually happen, because communities don't have those dollars to have these kind of prevention programs. Katie can easily speak to that this is this doesn't get funded so easily. I bet, Katie, that's something that you always would love to say to Senator Rush. How about some money?
Always.
Yeah. That's very true. And I also want to add that women talk differently. When we can have conversation, I can have a conversation with a perfect stranger in a ladies' room and ask her something completely personal, health related, and we will have an open conversation about it and share experiences. And guys don't do that. So I found out when I first started getting involved in educating myself and wanting to educate my community, you know, just being naive and thinking, well, let's get a group together where guys will go and talk about it. And of course, that's not reality. You know, women will do that. We could do a wine night or something like that. But so that's one of the other burdens is getting the information to men. How do you do it? Who do you do it through? And our focus was through the women. Or you know, I think our health fair really kind of tried to focus on sports. We did something baseball related, and then focused on kids and families, and had the mom like bring the children and bring the husbands. So
no, those are all great ideas. And you know, Tony, the one thing I want to talk with you about is that we're going to do a basketball tournament. You know how, you know, some type of basketball or football. We go hard in my family for sports, and you will get a lot of men to focus in on the sports. So you get a little bit of sports, let's get a little test. So we will definitely be continuing this conversation. Faye, you know, it just opened up so many more ideas for me today on this call with some of the comments and whatnot we've heard from the panelists. So the work is just beginning, okay, for us. So please, I'd like to thank each and every one of you. It's been phenomenal to have you all on here. Those of you who I have your phone number, you know I'll be calling you. I'll leave you alone tonight, but I'm going to call you in the morning. We've got some plans to go in. And Senator Rush, you're on that list as well. So
I'll be waiting for the call.
Thank you so much. Thank
Kathy,
you.
before you go, I want to say something to Tony, please.
Sure. Mm-hmm.
Could we get together at some time and have a conversation so that we could do a joint venture on the gift cards and food disparity and get some information?
Definitely. We did it last time with some of the pastors. Right. They left us out, and you know, it started raining, and they went in. I thought they were gonna pray for us. They left us outside.
No, last year, some of the food cards from the campus came from my area. So you and I need to talk about that and see what.
So we connected with some of the churches.
How we utilize that.
Yeah, let's try to up the ante. Let's get it to 30,000 this year. So
exactly,
make it happen.
Exactly.
Thank you,
Dr. Carter. I'm so thankful to our friend Horace for putting us together. Horace Small. So I will be in touch with you. I have your contact information now. Harold, as always, Katie, Reverend Brown, Tony. Thank you all so much. And I'm going to have Dr. Stern give some final comments before we close.
Sorry, I just got myself off the mute. Thank you so much. And also, I would like to have a chat, particularly with Dr. Carter, to follow up with Reverend Brown and Tony Clark about how we can get our resources to the communities you serve. Okay, so we'll follow up to sort of brainstorm how we can join our efforts to actually jumpstart the clinical care equity program in prostate cancer.
Excellent. Absolutely. All right, we got more work to do.
A great evening.
Thank you all. Happy holidays.
Good night, everyone.
Talk to you soon. Bye-bye. Thanks.